Here in chapter 14, we are going to talk about epidemiology and how diseases spread, some of the terminology, actually a lot of terminology, as well as vaccination. So some of the basics, first of all, just what epidemiology is. It's just a field of medicine that studies disease or adverse occurrences in a population. So they notice patterns of health and disease. So sometimes their work is kind of characterized by the 5 W's. So who, what, when, where, and why. Are these occurrences happening? To whom? And again, where are they happening? What's happening, etc. So some of the tools that they use, again, some of our terminology, prevalence of a disease, that's the total number of existing cases to the entire population. So if there are 500 cases of COVID, that's the prevalence. Whereas incidence is the number of new cases. So if there are 500 total, but only 5 of those were just reported, the incidence number would only be 5. And then the mortality rate is the number of deaths due to a certain disease. So again, the number of COVID-related deaths would be the mortality rate. So some of the curve patterns that are seen and kind of defined. So we have a point source epidemic. This is where the infectious agent is from a single source. So it's from one microbe, one food, something. So all victims were exposed at the same time. So it was just, so like potato salad at a picnic, that would be a point source epidemic. Whereas a common source epidemic, it's still exposure to a single source, but it could occur over a period of time. So if there was an agent that was released, but it's kind of continuously exposed, and so over time, we continue to see increases in those disease numbers. So that would be a common source. So both of those are coming from a single source. It's just point source is that everything happened at one time. Common source is it happened over a period of time. And then our last one, the propagated epidemic. This is where the infectious agent was communicable. So it's from person to person, and it is propagated over time. So here we have transmission between people, and it occurs over time. So for example, influenza is an example of a propagated epidemic. So some other terms here that go along, again, lots of terms in this chapter. Index case, this would be the first patient found in the investigation. If something is endemic, it means that that infectious disease exhibits relatively steady frequency over a long period of time. So again, relatively steady frequency. So we don't see blips, it's just kind of a flat line over a long period. Whereas sporadic disease, these are occasional cases that have irregular intervals. So again, endemic's kind of constant. Sporadic, we have kind of up and down peaks as far as how many people show up with that disease. Then epidemic is where statistics indicate prevalence of either endemic or epidemic increasing beyond what's expected. So again, if there's we had the epidemic of COVID. So COVID had been in existence, but huge numbers started to be seen, so that became an epidemic. So it's above what's expected. So the exact percentage is needed before an outbreak can qualify as an epidemic. So it has to reach a certain level or threshold. And then we also have pandemic, and this is where things are moving across continents. Again, COVID, another example there. So it was in China, it was in the US, it was in Europe. So it was a pandemic. Now, the natural history of diseases. So epidemiologists holistically think about disease. So they study 4 stages. So the 4 stages of this history, they look at the susceptible host. They look at subclinical disease. They look at the stage of clinical disease. And then they look at the recovery, disability, or death. So again, susceptible host kind of starts it. So we would have an exposure time. Then we'd be at a subclinical disease, so we start to see some pathological changes, but then we actually get to the clinical disease. This is where those symptoms actually start to occur, and this is usually when it would start to be diagnosed. It's like halfway in there. It can take some time to diagnose what the disease actually is. And then there will be recovery from the disease, or unfortunately disability or death. So if we go through each of these stages, say in the first stage, the susceptible host. So this is the person who has not yet encountered the agent, but will result in an alteration. Then subclinical disease. This is the period after exposure where damage is not apparent. So there are no signs or symptoms. Nobody could detect it. So it's at a subclinical level. Then we actually reach the clinical disease, and here there are obvious effects. So there are some signs and symptoms that are possible, and essentially then there are three options. Either there's complete recovery from the disease, or there's some type of disability, so some remaining symptoms. We usually think about disability as being something severe. That may not always be the case. It may be mild symptoms, but again, there's persistent symptoms that occur and never completely recover, or ultimately it could lead to death. Now, how do we actually detect the diseases early? So there are different screening tests that can be used. These are meant to be non-invasive, typically cheap and easy to perform to detect the disease even before symptoms can occur. So this would be deployed on healthy populations to detect it before any harm. So again, screening, kind of like early detection. And this is different though from diagnostic tests that are actually diagnosing what it is, because again, diagnostic tests are usually more invasive, with some more hazards, and with less patient acceptance. So people aren't as likely to be like, oh, sure, run that diagnostic test, and they can even have lower accuracy. So some of the screening tests, so positive screening tests are usually followed by more accurate diagnostic testing. So for example, Pap smears are a screening test that is done looking for cervical cancer, but if something is kind of indicated, then a biopsy would be the diagnostic test to follow. Again, more invasive than that screening Pap smear. Now, sometimes screening tests can be used as diagnosing tools. So for infectious diseases, again, the screening can be the final diagnostic test. For example, COVID-19 screening. Again, it's a screening test that can be done, but it would also diagnose what the disease is. Some other examples like an influenza test, a lot of the STDs as well. So again, sometimes the screening test is the diagnostic test as well. But again, it's important to understand the likelihood that the tests are accurate or inaccurate. So they may have a false positive or a false negative. So it's always important to know the percent of accuracy with them. A couple terms here related to these screenings are specificity and sensitivity, because again, false positives and negatives are possible. So what happens with specificity, how specific the test is, this is related to how many false positives we get. So this is where the screen calls them positive, but they actually don't have the disease. So how specific the test is determines how many false positives we get. Whereas how sensitive it is, or the sensitivity, is related to the false negatives. So these are people who actually are positive, they do have the disease, but they're found to be negative. So again, both of these are important to understand with any of our screening tests. Causality is another important part. So this is the actual causative agent. So then that brings us back to the Koch's postulates of determining what the etiological or causative agent is, and the 4 steps to determine that. So a lot of molecular techniques that we'll learn about more in the next chapter, like PCR, are important for identifying those as well. So the only sure way a factor can be found, though, is to take a healthy subject and expose them to the factor and see if they get the disease. So for the study of human disease, definitely unethical to do that to determine that proof of causation. So animal models are typically used. So correlation and causation. So correlation is observed when one of the studied variables changes in the same direction as the other. So they seem to be related or correlated. But without more information, observed correlation does not indicate causation. So in order to prove causation between an exposure and an outcome, we have to perform an actual experiment, have a control group that does not get the exposed factor. Again, with people, it is unethical, though, to expose healthy people to a disease-causing agent, so they use the animal studies. So again, if it seems that a disease is caused by a particular agent, then you would, in an animal model, expose some mice to the agent, not other mice, and see what happens. Is there disease only in those receiving it, or to determine whether that is actually the cause. So this is what a correlation graph would look like. So for example, here we have divorce rate in Maine, and then also consumption of margarine. So this is trying to show that the divorce rate correlates with the consumption of margarine, which is kind of weird, but it still shows the point. But again, we can see that these trends go together. So whenever one decreases, the other decreases. So they seem to be correlated. But again, then you would have to design an experiment, again, treat some groups that would have a lot of margarine, others that wouldn't, and determine then the divorce rate. All right, now surveillance and notifiable diseases. So surveillance, this is the collecting, analyzing, and reporting of rates of occurrence, mortality, morbidity, and transmission. So again, surveillance, we're just thinking about kind of keeping data, just taking all of that in. So it involves, again, keeping the data on large numbers that's seen in the medical community. Then we also have what are called notifiable or reportable diseases. And this is where it is by law. There are some diseases that have to be reported to authorities, whereas others are just reported voluntarily. And these reported diseases, they're that way because they're highly contagious, very dangerous, and very unusual. So like Ebola, for example. Again, if that pops up, somebody needs to know about it. So surveillance is more generic and general, just kind of keeping track of things, but there are notifiable diseases that have to be reported to the authorities. So these diseases that are reported are at either the local, state, national, and international level. So it's not just one authority typically that gets it. It's multiple branches. So the physician and hospital report all notifiable diseases that are brought to their attention. Depending on that disease, then the reports are made either about the individuals or an aggregate. So is it just about one patient, or is it about the ones that they've seen in their practice? And then the government agency responsible for keeping that is the CDC. So that's who it gets reported to. And then morbidity and mortality reports, there are weekly notices that are published by the CDC on these diseases. Now switching over to healthcare associated infections. So these are infections, as the name implies, that are acquired or developed during a hospital stay or some type of healthcare facility. So these are particularly ones that we see in a healthcare setting. So it's estimated by the CDC that there's about 1 in 31 hospital patients and 1 in 43 nursing homes that have one of these healthcare associated infections. So again, that's pretty prevalent. Okay, there's quite a few of those that are happening. Now the top 4 of those catheter-associated urinary tract infections, especially thinking about nursing homes where it's more likely, but also in hospitals, catheters are commonly used. So getting urinary tract infections from those. Again, if you weren't in the hospital, weren't in a healthcare setting, you wouldn't have a catheter. So it's a healthcare associated infection. Also central lines, leading to bloodstream infections, surgical site infections from improper aseptic technique and sterilization, and also ventilator associated events. So the main sources, again, catheters, central lines, surgery, and ventilators. So the trends in most of these HAIs. So these trends are good trends that we have in this case. So about a 31% decrease in central line associated have been seen between 2015 and 2019. A decrease in about 25%, 26% of catheter association. MRSA bacteremia, which is methicillin-resistant Staph aureus, that's down about 18%. Unfortunately, no change to the surgical site infections. However, during colon surgery, there has been a 15% decrease in those. And then the C. difficile, so those are especially, again, one of the ones we get super infections from by treatment of antibiotics. Those are down by about 42%. So again, as the public is more aware, especially healthcare, we learn more aseptic techniques, better ways of preventing disease, and put those into practice. We're starting to see a national decrease in this. So we are definitely seeing progress as a nation in these infections. So how are these controlled then? So again, this doesn't just happen. There have been many efforts to control them. So Medicare and Medicaid stopped reimbursement to hospitals that had the catheter associated UTIs, the central line blood infections, and the surgical site acquired infections. So that is a huge motivation for hospitals to decrease those. If they're not going to get compensated for them, any bills that occur due to those because they happen in the hospital, that's a huge motivator to start implementing some better techniques. So some universal precautions, again, medical asepsis. So again, just in all medical supplies, ensuring that everything is properly treated and disinfected, that it's sterilized properly if that's the case, especially surgical asepsis and removal of those microbes. And just having positions called infection control officers that are keeping track of these things, that can identify issues and allow for preventative measures to be taken that can decrease all of these HAIs. So the hospital then is a source of disease. So this medical asepsis, so some examples of that, that's the hand washing, again, proper disinfection and sanitization, isolating patients to decrease the communicable transmission, also decreasing the medical or the microbial load in patients, the caregivers, and the environment. So using those HEPA filters, using things that decrease the amount of microbes that they're exposed to. And then some examples of the surgical asepsis. So again, those strategies, plus ensuring that all the procedures are conducted in sterile conditions. So not only the equipment, but also just the way in which they're doing the surgeries. So then the infection control officer, they're implementing the proper practices. So they track potential outbreaks, they identify breaches of asepsis, and they're involved in the training to help with that aseptic technique. Switching now to vaccines, so they play a critical role in controlling infectious disease. So of course we talked already about controlling and like disinfecting and aseptic technique, but this is ways of preventing the actual disease. An important concept here is herd immunity. So this is when a significant portion of the population becomes immune. It helps limit further spread of the disease. So those who are not immune, who are not vaccinated, whether they're too young to be vaccinated or they choose not to be, they are indirectly protected from the disease because it can't be spread because so many are vaccinated. So it can't be, again, passed on because the majority of people are vaccinated against it. So it's achieved, though, either through having survived the disease or being vaccinated. And there are lots of layers of trials and experimental animal and human volunteers that the vaccines go through before they can be licensed. So this is just a visual looking at herd immunity. So we'll start down here when there isn't immunity. So there's either not a vaccine or people haven't been exposed to it. So using the coronavirus as an example. So in this case, we have predominantly healthy individuals. They're, again, not immunized, either not vaccinated or haven't been exposed. And then we get one case of this communicable disease. So over time, that person who was originally exposed, they will become naturally immune. So as long as they survive, then they've been exposed to it. So that's a natural immunity to it. However, they are going to pass that on to pretty much everybody else in the population. And that, of course, will lead to some deaths. But then also, again, over time, these other people would become immune as well. So if there's no immunity, again, lots of people are going to become infected, and ultimately the death rate would be pretty high. However, if there's herd immunity, now what we have is a mixed case to where the majority of people in the population have been immunized, either again by vaccination or naturally immune because they had it. And then we have some, which are shown in green, that have not been vaccinated. So what happens here whenever we still get one case of the coronavirus, over time, that person is now naturally immune. But as you can see, unlike what we see below, very few of the people end up getting. So we only have one of the healthy people that weren't vaccinated getting the virus because they are kind of naturally protected by the immunized people. It doesn't spread through the population like it does when there's no immunity. All right, so this nice summary figure has a lot of information on it. So let's just start first with how new vaccines are developed or approved. So they're essentially, and this is similar for drugs as well, but essentially there are 3 phases of clinical trials. So after, it has been shown in like a cell culture or in an animal model, which can take years and years, or sometimes they can be done very quickly depending on the type of vaccine. But whenever they reach a point to where it's ready to be conducted on human trials, the first phase is just essentially a small number. So just to initially determine that safety, so about 20 to 100 healthy volunteers are vaccinated against it, determines if it's safe, does it seem to work, any side effects especially, and then the dosing that is used. Then after all of that seems to be okay, if all of that is okay, it moves on to phase 2, and now it just ramps up. So about several hundred volunteers. So now, again, looking for some really common side effects because, side effects can vary, and so a smaller population in phase 1 isn't really enough to truly give a lot of information about side effects. So the phase 2 really looks at the side effects as well as how the systems are responding to the vaccination. And then finally, if all of that still looks promising, then in phase 3, now we're at hundreds or thousands of volunteers. And this is just looking more at kind of the long-term comparing those who are vaccinated to those who were not, just ensuring that safety and effectiveness, that it is helpful, as well as continuing to look at side effects. And then the FDA is looking at the safety and effectiveness, as well as do the benefits outweigh the risk. If all of that is okay, then it is will receive FDA approval. So now we can also have a U.S. recommended schedule that determines the safety of when the vaccine should be given. So what ages should it be given to? How well does it work in different age groups? How serious is the disease that we're vaccinating against? Is it life-threatening or just rather a nuisance kind of disease? And then also how many children would get the disease if they didn't have the vaccine. So then those recommendations are not official, though, until the CDC reviews and approves them. So that starts with the Advisory Committee of Immunization Practices. But those recommendations go to the CDC, and then that would go into the recommended scheduling. And then after vaccines are put into some type of schedule, they've been approved, then there is continued monitoring for safety and effectiveness, and that's the job of both the FDA and the CDC to monitor vaccine effectiveness, to look for any adverse events. So there's a reporting system called the Vaccine Adverse Event Reporting System, VAERS, and that's where, just kind of like notifiable diseases, this is a system in which healthcare providers can report any unusual or any adverse effects following vaccination. And then there is also the VSD, which is the Vaccine Safety Data Link. And this is a network of healthcare organizations in the US. And essentially, this is just a database to where various healthcare providers can see information on the effectiveness and the use of vaccines. So mainly scientists are going to use this to conduct studies and evaluate the safety of vaccines. So again, the VAERS is a reporting system, and then the VSD is a data bank for people to get information. So just a little bit more about those. So again, the Vaccine Adverse Events Reporting System, this is a centralized system, as the name implies, for reporting those effects that happen after a vaccination. So anyone can actually make a report whether the adverse effects is related to the vaccine or not. So the patients, the parents of the patients, or the healthcare provider. So it's not just limited to healthcare. Then some of the global issues with that epidemiology. So there are emerging diseases, and these are caused by newly identified microbes. So whether it's a new strain of a virus like COVID-19 was an emerging disease, or like something just that is new like Ebola, new strains of influenza. But then we also have re-emerging diseases. And so this is where it was an issue in the past, but that level went down. However, now due to changes in travel or habitat or drug resistance, now we're starting to see more cases of that disease than had been in the past. So ways to monitor this emergence. So there's the Global Disease Detection Service. This is a collaboration between the CDC and the World Health Organization, as well as local governments. And this is just monitoring disease emergence to try to spot and limit epidemics. The CDC also monitors various situations with health and disease, as well as creating strategies to decrease excessive morbidity and mortality. So like the mask policies, isolation, coming up with recommendations to try to decrease the amount of deaths and injury due to disease. And then finally, just wrapping up with how, unfortunately, agents can be used for bioterrorism. So this is intentional or threatened use of microbes or just their toxins from living organisms to cause disease or death to either humans, livestock, or plants. So in 2001, there was bioterrorism of anthrax. This has been one of the most notable events in the US, to where, again, it's a spore former, so those endospores were targeted. They were sent in the mail to various organizations. They were aerosolized. But again, the idea is using these microbes to harm other people or livestock or plants. And then terrorism is using those microorganisms to disseminate the agricultural industry. So different government agencies kind of conduct surveillance and have different policies to prevent or inhibit that type of scenario.